Good afternoon, good morning, bienvenidos. I'm Joanne Elena, a program director in NCI's Division of Cancer Control and Population Sciences. And on behalf of my co-chairs, Dr. Tram Lamb and Dr. Shobha Srinivasan, I'm so pleased to welcome you back to day 2 of our workshop, Cancer Epidemiology in Hispanic Populations. Yesterday's program was fantastic, and I'm looking forward to another full day of informative talks and lively, spirited discussion. We started off yesterday with 2 NIH powerhouses, Dr. Bob Croyle and Dr. Eliseo Perez-Stabley, who have been championing cancer epi research in Hispanic Latino populations for quite some time now. There was considerable discussion around the terms Hispanic Latino population, and we heard stories about not identifying with established race, ethnicity categories. I think one presenter revealed her response to forms saying, am I white? Am I Black? I don't feel white. In response to words like Hispanic or Latinx that don't really speak to all the people that we might wish to put in that box. These terms are designated by other groups. The terms we tend to use in research were designed by OMB for different purposes, rather than trying to understand health determinants or self-identification. Or in my case, twice, having to correct our pediatrician's office that I intentionally selected Hispanic, and it's not a mistake because it didn't fit their picture. Understanding how these seemingly minor things really could affect health is vital. I was struck by another speaker who mentioned patients not qualifying at her institution for clinical trials when race information wasn't complete if they didn't select one because it didn't feel like it represented them. That's directly affecting health. As an epidemiologist, I dream of easily discernible, clear-cut variables, but this is real life. And yesterday's talks from our many SAGE experts highlighted the complexity in accurately, meaningfully, and respectfully identifying our population of interest and the risk factors needed to mitigate cancer burden. We heard about work highlighting genetic, behavioral, clinical, geospatial, cultural, and many other risk factors for developing cancer and for cancer outcomes in our cancer survivors. This morning, I was greeted by an email from our NIH director, Dr. Francis Collins, celebrating the first day of Hispanic Heritage Month and reiterating his support for scientific research that includes people from Hispanic Latino backgrounds, and importantly, by scientists of Hispanic and Latino backgrounds. This year's theme is Esperanza. My hope for our meeting is that we continue the discussion. So many of you, those attending this meeting, and we had almost 300 of you in attendance yesterday, to continue your discussion and identifying the important gaps in research and collectively brainstorming ways around our challenges to chip away at those gaps. Small steps to get us to our ultimate goal of improving the health and well-being and reducing cancer burden in Latino Hispanic populations. It's a big goal, but yesterday's presentations and today's presentations as well really give me hope. Okay, we have a few technical announcements. Number 1, all participants are muted. If you have a question and moderators are accepting questions from the audience, please virtually raise your hand on Zoom. If you have questions, you can always chat the host, and we will tell you how to do that. And then once you've raised your hand, we'll unmute you. The Q&A box is consistently monitored and it allows for discussion throughout the meeting. I've noticed many speakers will take questions after their session and you can get a response there. In the unlikely event that a speaker goes over time, you will hear a chime. It's not an errant cell phone, as I thought it was yesterday, and I heard from many of you. That's letting everyone know it's time to wrap up and as quickly as possible. Finally, we are recording these sessions. The talks will be available on our website once formatting is finished, probably a month or two, and we will email all registrants to let them know it's available. At this time, we are not planning to share any slides. We know it can be a really long afternoon on Zoom, and we appreciate your attention and your participation. We'll try to channel some of the spirit and energy from Independence Day celebrations going on this week into the rest of the meeting and keep us going with our lively discussion. So thank you to everyone who's been a part of this meeting. And with that, I'd like to turn it over to my colleague, Dr. Gabriel Lai, also an epidemiologist and program director in the Division of Cancer Control and Population Sciences, to start off our morning. Gabe.
Thank you, Joanne, and thank you to all. Welcome everybody to our second day for this wonderful workshop. I'm hoping that this will continue the energy that we started yesterday. As you can see from the slides, our session will be on surveillance and research challenges, and we have three wonderful speakers that will be speaking on various aspects in relation to surveillance. We have Kathy Cronin here at the NCI. We have Maggie Kulishevsky from the New York Cancer Registry, and Paulo Pinero over from the University of Miami Miller School of Medicine. And I really want to take advantage of the time. So the speaker bios are all available for you in terms of details, but just very briefly, and I'm going to introduce the first speaker. We have Kathy Cronin. She is the Deputy Associate Director for the Surveillance Research Program within NCI's Division of Cancer Control and Population Sciences. And she works closely with the SEER program of cancer registries that collects information on cancer incidence, survival, prevalence, and mortality. And I'm going to hand it now the baton to Kathy to begin this session.
Hello and good afternoon. I hope everyone can hear me okay. Thank you for inviting me to talk this afternoon. I really appreciate the opportunity. I was asked to talk about cancer registries and the challenges in collecting Hispanic subpopulation information. So when I started putting this together, I decided that I should really focus in, because this is such a large topic. So I'm going to really focus in on challenges associated with the standard statistics that the SEER program reports each year. And so that's incidence, survival, and mortality. And I realize, of course, this is a great underestimate of the value of registry data for looking at risk in Hispanic subpopulations, since the registries support research in many different ways, including special populations, where they go out and collect additional information in addition to what's routinely collected by the registries. But since, trying to move them, but since the time is limited, I decided to really limit this talk just to a couple topics. So I'm going to talk a little bit about the information that goes into the mortality rates, the information that goes into the incidence rates, a little bit about nativity in the SEER program, and population estimates. Before I really get started, I thought it was important to spend a little bit of time on the background, because it's so important to understand where this data is coming from and how it's collected to really understand the limitations of the data and how it affects the rates and other statistics that we report. So as people probably are aware, population incidence rates and survival estimates are calculated from registries data. But unlike some of the discussions yesterday where we talked about going out and surveying patients, that can be done in special populations, but it's not routinely done in registries. Registries do not collect information directly from the patients, but abstract information from existing medical records and also through linkages with other data sources. So it's not primary data collection, but it's really consolidating data that already exists in a number of different sources. Mortality does not come from the registries, at least the mortality rates that we distribute every year. They come from the National Center of Health Statistics, and the mortality rates are based on the information that's found on the death certificates. And so the results that I'm going to show in this presentation really represent a national studies and national statistics, but they may vary quite a bit when you're looking at smaller geographic areas. And also, I'm really only talking about data that's routinely collected by registries or through death certificates. I'm not really addressing all the special studies that could be done and other opportunities for research that utilize the registry system. So there was an interesting discussion yesterday about the accuracy and what that even means when talking about ethnicity and even more specifically subpopulations. So for this presentation, it's a pretty limited definition in that when we're talking about rates, we want the classification or the categorization in the numerator to match what's done in the denominator. And in the denominator, our population data comes from the census where it's self-reported. So when I talk about accuracy of the information on the death certificate or in the registry data for cases, I'm really trying to get an idea of how well does that information match what would be self-reported in the census. With an understanding, of course, that self-identification is not a constant and it can change over time, but that's what we're trying to look at. So I found that this report was very useful. It's from the National Center of Health Statistics, and they've published a series of them. This one was published in 2016, and they compare the race ethnicity found on death certificates with the National Longitudinal Mortality Study, which is a study that includes a series of surveys, current population surveys, where people self-report race and ethnicity. And by doing this, they get an idea of how well the death certificate information would match self-report based on these surveys. So they report a sensitivity of 88%, 88 to 89% overall for Hispanics, but it's a little bit lower for subpopulations or a little bit different. It was 85% for Mexican, 84 for Puerto Rican, 92 for Cuban, and then it was much lower when you started to look at other groups like Central or South America. And I did want to point out that 88% doesn't mean that the mortality rates are underestimated by over 10%. Misclassification can go in both directions. So 88% says of people who self-identify as Hispanic, 88% of them are listed as Hispanic on the death certificate. But there could be people who are listed as Hispanic on the death certificate who don't self-identify as Hispanic. So this report also calculated adjustment rates, and for overall Hispanic, the adjustment rate was 3%, which was suggesting that it was that mortality rates would be underestimated by about 3%, which didn't explain the difference between mortality rates in Hispanics versus non-Hispanic whites. It also included this graph, which I thought was very useful. And the x-axis on this is what's self-reported. And then the bars show what was actually on the death certificates. So for example, the first set of bars are people who self-reported as being Mexican, and 84% of them were listed as Mexican on the death certificate. But 7.1 were other Hispanic and 7.7 were non-Hispanic. And so you can see there's a lot of misclassification even within the subcategories of Hispanic. They also looked at how the misclassification would vary by age or by sex age distribution. And it was relatively stable overall and for Mexicans, and it varied a bit more for Puerto Rican and Cuban, but it was very variable for Central and South America and other groups. They also had some general conclusions, and that was that ethnicity was more likely to be correct if classified as foreign-born, as you might expect, because that gives you some additional information. Excuse me. Also, place of residence also affected accuracy of ethnicity. Residents where co-ethnics were numerous had a positive effect on the accuracy of the information on the death certificate. So we also looked at race ethnicity within SEER variables, so to give information about incidence. And we did a very similar study by comparing the race ethnicity variables in SEER with self-report using the same NLMS, the National Longitudinal Mortality Study, comparing it with self-report on the surveys. And we found a slightly lower sensitivity of 84% for Hispanics. But when you look at subpopulations in the data in SEER, it really tells a complicated story and highlights one of the real challenges. The majority of people were listed as Spanish NOS, which means not otherwise specified, or were listed as Hispanic based on an HIA algorithm, which is an algorithm that uses surname to identify people as Hispanic. So there really was not good enough information to look at incidence rates by subpopulation. And also it varied by whether a person was alive or had died, with the information being more complete if the person had died. So since incidence rates is so difficult for subpopulations, there's a lot of interest in nativity variable in the SEER data to look at people who were born in the United States versus outside. So this is a variable that we used to release in our public data sets, but we removed it several years ago. And the reason we removed it was there was concerns about bias. The information is much more likely to be complete if the person had died, and it was more likely to be missing if the person was still alive. So in the most recent data, the percent of unknown in SEER was 64% for people alive and 21% for people who have died. So if you did a survival analysis and excluded unknown, it would really bias your estimates. So we're currently estimating, or we're currently investigating potential sources to supplement the information on nativity. And there's a pilot going on with the Social Security Administration, which we hope will help. The last thing I wanted to talk about was population estimates. And of course, the validity and reliability of any rate is going to depend on the accuracy of the estimation of the population. And the decennial census does give us population estimates by age, gender, and geography for subgroups. But if you want to look at intercensal years, it has to be modeled. And people are not only interested in incidence rates at one point in time, but looking at trends. So we have been working with a group that does this type of modeling to see if we can estimate Hispanic subpopulations between 2010 and 2020. Another thing that's on the radar that we've been thinking about is the census is using a differential privacy algorithm starting in the 2020 census to help with confidentiality. And it's a little unclear how much this is going to impact subpopulations, particularly in small geographic areas. And the final slide that I have is just to highlight how important it is to think about how data is collected and where it's collected. This is when we started looking at modeling subpopulations from 2010 to 2020 based on the census. We're looking at the census form. And when they ask about race, they specifically say to mark one or more boxes. But that wording isn't there when they ask about ethnicity. And so we started to think, well, is this going to affect the way people answer the question? And this is the data that we'll have to model populations from 2010 to 2020. And it's also the data that we'll be using to model from 2020 to 2030. So how the question is answered and how people interpret it and respond it is really going to impact our population estimates as well. So I think that my time is up, and that's just a very quick overview. I'd be happy to answer questions during the discussion period. Thank you.
Thank you so much, Kathy. I think you got it just in time. And just as a reminder, we're going to have our questions we'll have questions for the speakers after all speakers have gone. And so again, I remind folks to please leave questions in the chat or in the Q&A box, and or during the discussion panel, you are certainly welcome to raise your virtual hand. Our next speaker will be Dr. Maggie Gates-Kubashevsky. She's currently a research scientist at the New York State Cancer Registry, where she leads the registry's research unit and co-leads the analysis and output unit. And she also holds an appointment as an assistant professor of epidemiology at the University at Albany School of Public Health. And she'll be discussing her experiences within the New York State. And now I'll leave it to Maggie to speak.
Hi, can you all hear me?
I can hear you, Maggie. Go for it.
Great. So good afternoon or good morning to those in other time zones. Next, I'm going to present an example of using cancer registry data to examine Hispanic ethnicity, migration, and cancer survival using data from the New York State Cancer Registry. I wanted to start by showing the race ethnicity distribution for cancer cases diagnosed in New York State and for CR18, which covers approximately 28% of the US population. Between 2000 and 2013, 8.3% of cases diagnosed in New York State were in individuals of Hispanic ethnicity, which is similar to the estimate of 9% for CR18. However, looking across time and including more recent cases diagnosed in 2014 to 2017, the percent of cases with Hispanic ethnicity has increased over time in New York State from 8.4% in 2000 to 2004 to 11.4% in 2014 to 17. And this percentage will likely continue to increase since approximately 19% of the New York State population was Hispanic in 2013 to 2017. The most recent cases are included here to show the changes in the race ethnicity distribution over time, but I didn't include them in subsequent slides looking at survival. This slide also shows a limitation of the registry data that I've outlined in red here. And Kathy mentioned this as well, where information on birthplace is often missing and frequently is obtained from death certificate information. As a result, the more recent cases are more likely to have unknown birthplace, and cases with unknown birthplace tend to have more favorable characteristics, such as a higher percentage of local stage cases and a younger age distribution, since these cases are less likely to have died. Looking at the distribution of Hispanic subgroups for cancer cases diagnosed in New York State between 2000 and 2013, approximately 25% were Puerto Rican, 17% were South American or Central American, 11% were Dominican, 3% were Cuban, and 3% were Mexican. And the remainder were other specified subgroups, Hispanic, not otherwise specified, or were Hispanic based on surname only. The Hispanic subgroup distribution in New York State is very different from the distribution in the rest of the US. Looking at the overall population in 2013 to 2017, New York State had a much higher percentage of Puerto Rican, Dominican, and South American individuals, and a much lower percentage of Mexican individuals compared to the US as a whole. Before moving on to the results of survival analyses, I wanted to briefly mention some of the challenges of using cancer registry data on Hispanic ethnicity, and Kathy already touched upon several of these. The availability of data on birthplace and Hispanic subgroup are advantages of the registry data. However, this information may not be collected or reported accurately, and there may be misclassification in the data. For example, there may be issues with the accuracy of the Hispanic subgroup data, especially when birthplace is missing. In addition, missing data can be an issue for several of these variables, but especially for birthplace, since a high proportion of cases have missing data, and the characteristics of cases with and without the missing birthplace data differ. Another potential limitation is that often analyses use broader race ethnicity categories to have a large enough number of cases. However, using this broad Hispanic category may mask differences between the Hispanic subgroups. Also, for survival analyses using registry data, the unavailability of follow-up data could be a larger issue for certain subgroups, such as Hispanic individuals born outside the US. This could include cases who are diagnosed or treated in a certain state, but who aren't followed up, such as seasonal workers, individuals who come to the US to receive care, or other individuals who return to their country of origin after diagnosis. These scenarios could make survival look better than it actually is for these individuals if we don't capture this information on their vital status. So acknowledging these potential limitations, the next several slides look at race ethnicity and Hispanic origin in relation to overall survival. Examining race, ethnicity, and overall survival for cancers diagnosed in New York State between 2000 and 2013, the hazard ratio is highest for non-Hispanic Black individuals and for Hispanic individuals who have a 28% and 26% higher mortality hazard, respectively, when compared to non-Hispanic white individuals. The hazard ratios are also elevated for non-Hispanic Asian Pacific Islanders and for individuals of other races. This analysis in the first column includes individuals with unknown birthplace, which was 23.6% of the cases diagnosed in 2000 to 2013 at the time of this analysis. However, the next two columns in the table are stratified by birthplace and exclude individuals with unknown birthplace. So again, some potential issues here, excluding the unknown birthplace cases. Among Hispanics, the hazard ratio for US-born individuals is higher than that for foreign-born individuals, which is also the case for non-Hispanic Black individuals. It's possible that the foreign-born individuals truly have better survival, or this could be related in part to missing death information for foreign-born individuals, which would be expected to artificially inflate survival. In these analyses, we used active follow-up information instead of presuming an individual is alive if they are not known to have died, but non-random censoring by racial ethnic group could still be an issue here. As noted earlier, a limitation of this analysis is that it doesn't provide any information on possible differences by Hispanic subgroup. And in addition, the exclusion of individuals with missing birthplace likely impacted the results, since these cases tend to have better prognosis. The next slide shows a similar analysis, but looking at each Hispanic subgroup separately compared to non-Hispanic individuals, which includes non-Hispanic individuals of all races. The overall column includes individuals with unknown birthplace and shows the highest hazard ratios for Puerto Rican, Mexican, and Cuban individuals, although all Hispanic subgroups had elevated mortality compared to non-Hispanic individuals. Stratifying by birthplace, the mortality hazard is higher for US-born versus foreign-born Puerto Ricans and South Central Americans, and survival is better for US-born versus foreign-born Mexicans. Again, some of these differences could be related to missing follow-up data, and the exclusion of individuals with missing birthplace may have also impacted the results. In addition, there may be issues with misclassification of Hispanic subgroup, although again, that's more likely when birthplace is unknown. The next few slides include just the cases with known birthplace. So this slide looks at the association between country of birth and overall survival among Hispanic individuals only. Compared to individuals born in the United States, those born in Puerto Rico, the Dominican Republic, Cuba, Central America, South America, and other foreign countries had better overall survival. No association was seen for birth in Mexico compared to the US. Some possible contributors to these associations could be differences between first-generation immigrants versus subsequent generations, or missing follow-up information related to individuals returning home to their country of origin, or other possible reasons that deaths might not be captured. The final few slides show Kaplan-Meier curves for overall survival, stratified by birthplace, first for cancer sites that tend to have high survival, and then for sites that tend to have poorer survival. The high survival cancer sites included here are prostate, breast, uterine, kidney, colorectal, and cervical cancers. For US-born individuals shown on the left, the best survival seen was for non-Hispanic Asian Pacific Islanders, which are shown in blue, followed by non-Hispanic white and other race individuals. And the poorest survival was seen for non-Hispanic Black individuals shown in green and Hispanic individuals who are shown in yellow. Among foreign-born individuals, these individuals had better survival overall, with the best survival for non-Hispanic Asian Pacific Islanders and the worst survival for non-Hispanic Black individuals, followed by Hispanic individuals. These results suggest a survival advantage for high survival cancers for the foreign-born versus US-born individuals, although this could be related to data issues such as missing follow-up information. Looking by Hispanic subgroup, among the US-born individuals, the best survival was seen for non-Hispanic and other Spanish Hispanic individuals, followed by Mexican, Dominican, Cuban, South Central American, and Puerto Rican individuals having the poorest survival. Looking at the foreign-born individuals on the right, most groups had similar survival curves, with the poorest survival for Mexican and Cuban individuals. And again, survival was higher overall for the foreign-born individuals. So finally, these analyses showed the poor survival cancer sites, which included lung, pancreas, liver, esophagus, and gallbladder. The survival curves were similar by race ethnicity, and also for US-born versus foreign-born individuals, with just slightly better survival for the foreign-born individuals, which again could be due to missing follow-up information. The results were similar when looking at Hispanic subgroups, with similar survival for most Hispanic subgroups, and also comparing US-born and foreign-born individuals. Among the US-born individuals on the left, survival was slightly worse for South Central Americans and Puerto Ricans, and overall survival was slightly better for foreign-born versus US-born individuals, suggesting a possible contribution of missing follow-up data. So in summary, we observed that the percentage of New York State cancer cases to identify as Hispanic has increased over time. However, this percentage is low compared to the proportion of Hispanics in the New York State population, since the age distribution of the Hispanic population is much younger than the overall population. We observed a higher mortality hazard for Hispanic versus non-Hispanic white cases, in particular for US-born individuals. And the differences in the survival curves were most pronounced for high survival cancers and also among US-born individuals. Salmon bias or other reasons for missing follow-up information may have impacted the survival for foreign-born cases, and non-random censoring by group may have also impacted the analysis results. Overall, additional work is needed to improve cancer outcomes in the Hispanic population, especially among US-born individuals who appear to have poorer survival. But in addition, I think more work is needed to analyze these data in more depth, and also to examine the contribution of various factors to differences in cancer survival by race, ethnicity, Hispanic subgroup, and birthplace. So thank you, and I'm happy to answer any questions during the Q&A.
Thank you so much, Maggie. That was very insightful and very informational regarding the New York State. Just to move things along, our third and final speaker for this session is Dr. Paulo Pinero. He is a research associate professor of epidemiology at the University of Miami Miller School of Medicine, and his research interests primarily focus on cancer incidence and outcomes in Hispanic, Latino, and other minority populations. And he's conducted a number of pioneering studies, some of which were cited yesterday, that examine cancer incidence, survival, and mortality patterns across detailed racial ethnic groups, including Cubans, Mexicans, and Puerto Ricans, among others. And now I'll hand it over to Paulo.
I'm a cancer epidemiologist and an associate professor at the University of Miami. My research focus over the last 15 plus years has been on developing a deeper understanding of the complex nature of population-based cancer indicators, incidence, survival, and mortality for detailed racial ethnic minority groups with a focus on Hispanics. Today, I will provide a brief and very summarized overview of some lesser-known patterns for Hispanics, with an emphasis on the current challenges and opportunities for studying cancer among Hispanics, including the diverse groups such as Cubans, Puerto Ricans, Mexicans, and so on. As a principal investigator, my funding comes exclusively from the state of Florida biomedical research programs, and I have no direct funding from NIH. According to the 2020 census, Hispanics in the US number 62 million. Thanks to SEER and NPCR registries, we have quite an extensive literature portfolio on the cancer experience of Hispanics as a whole. However, if you want to study the heterogeneity within Hispanics, there are considerable problems with the data in our surveillance systems. Our current data overwhelmingly reflects the experience of Mexican Hispanics, who make up 63% of all US Hispanics. The attention that our cancer surveillance systems give to different racial ethnic groups is uneven. For Asians, there is a quite complete race variable which allows for the study of distinct Asian groups. For the Black population, there are no distinctions made by unique groups, although they are arguably the most genetically diverse population and generally have the worst outcomes. So, in theory, they should merit additional effort. For Hispanics, we are somewhere in between those, with an existing variable on Hispanic origin in the registries, but one that is unfortunately highly incomplete. As you can see in this table, this is the variable that characterizes Hispanics, and overall the Hispanic group is unspecified in approximately 65% of the cases. This problem of incompleteness snowballs into different problems, jeopardizing the validity of any incidence or survival studies of Hispanic groups using registry data. We have published the following article that analyzes these problems in detail for any of you that may be interested. So where are we in terms of incidence, survival, and mortality in Hispanics? It doesn't come as a surprise that current knowledge on cancer incidence by Hispanic group is scarce, given the incomplete data. The last manuscript dates from 2009. Cubans, Puerto Ricans seem to have higher incidence rates than Mexicans, and liver, cervix, and stomach seem to be increased in all Hispanic groups. For survival, statistics from studies using SEER data indicate similar or only slightly lower survival for Hispanics than the white reference group for most adult cancers. Results are routinely framed in either two ways in the literature. If survival happens to be better among Hispanics than whites, they call this the Hispanic Paradox. Conversely, if Hispanic survival is indeed lower than that of whites, it is commonly framed in the classic context of socioeconomic disparities for minority populations. In any case, for the topic of survival in Hispanic subgroups, there is considerable publication bias. Unfortunately, survival in Hispanics is very challenging to study, as it is riddled with methodological problems. In summary, it is important to understand that survival depends on accurate knowledge or linkage of deaths among cancer cases, and that the demographic information on Hispanic groups often comes from death certificates. As a result, two specific challenges in Hispanic survival arise. Problem number one is incomplete follow-up, and that results from Social Security number bias, summon bias, and name biases. All of these three biases will result in an overestimation of survival for the foreign-born populations because we are unable to completely capture all deaths that occur in this group. Problem number two relates to the knowledge of a specific Hispanic group that is associated with death being an outcome of survival analysis. And this results from ethnicity and birthplace information often coming from death certificates. As a result, what happens is that survival is going to be underestimated for foreign-born populations as well as US-born populations, and paradoxically, Hispanics of unknown birthplace, which will correspond to the less aggressive cases, will have higher survival than the other two groups. This complex nature of this problem will result in confounded estimates for survival for Hispanics. In my personal experience, for instance, despite over 15 years of access to very detailed Hispanic survival datasets, these biases have resulted in me publishing only one paper on survival by Hispanic group, as I felt hesitant about the accuracy of the results that I was getting. So in short, how could we improve the situation for the use of surveillance data for incidence and survival? Well, there are several possibilities that I put in this slide. If the Cancer Center support grants from NCI would establish mandatory requirement for more detailed information on ethnicity and country of birth, that would certainly help, or at least incentivize the collection of this information. In terms of SEER and NPCR, linkages with the Social Security Administration for these data would be beneficial, as well as standardizing that linkages to contemplate both Social Security number and name biases. Finally, an important rule for follow-up among SEER procedures would be to make the 95% rule of updated follow-up race ethnicity specific, so that we would avoid imbalances in terms of complete follow-up that exist for Hispanics and whites. Now, in contrast to incidence and survival data, mortality data, which comes from vital statistics datasets rather than cancer registries, is quite complete on race, ethnicity, and birthplace variables. As such, mortality data can tell us a great deal about differences between different Hispanic groups, as you can see in this slide. However, since these data reflect mortality, we need to interpret them as the joint result of both risk factors and prognostic factors. In mortality studies, you can see that the common adage that Hispanics suffer from infection-related cancers like liver, cervix, stomach, or gallbladder at higher rates is actually not entirely true, and much more nuanced when examined by distinct subgroup. So we are seeing problems with other cancers. For instance, acute lymphoblastic leukemia, both in adults and in children, is a problem that is common to all Hispanic groups. Also, other specific groups are popping up. We have lung, prostate, kidney, colorectal, testis cancers, which are all understudied cancers among specific Hispanic groups. Among these specific groups of Latinos or Hispanics, US-born Latinos are one that is very specific and has received relatively little attention. They are 22 million in 2019, they are increasing rapidly, and according to the assimilation theory, we would expect cancer mortality rates among US-born to approximate those of US whites over time. What we have been finding, analyzing the data from 2005 onwards up to 2017, is that actually that is not happening, meaning that US-born Latinos show persistent rates for very specific cancers. And these cancers are, in common to other Latino groups, high stomach cancer and high cervical cancer, and more specific for US-born Latinos, high liver cancer and high kidney cancer and high colorectal cancer. If we put all these 5 cancers together, we see that these patterns are actually common with yet another racial ethnic group in the United States, American Indians or Native Americans. Given these similarities, it would be very interesting to study how common socio-environmental factors are simultaneously affecting these two populations. So given the challenges that I've just mentioned, are studies that use cancer registry data to focus on Hispanic groups impossible? My answer would be no, but one has got to be highly selective of what we're going to study. For instance, the more fatal the cancer, the more feasible the research is, because more information on subgroup will be available because that information comes from death certificates and is widely accessible. I'll give you an example. What I am studying currently, hepatocellular carcinoma in Florida. Why is hepatocellular carcinoma important? Because screening and treatment for infectious causes of hepatocellular carcinoma, like hepatitis B and hepatitis C, associated with clinical surveillance, can result in lower incidence and better survival. And of course, hepatocellular carcinoma has got a known high incidence among Hispanics. So what we are doing here is to link all cases of hepatocellular carcinoma diagnosed in Florida from 2005 to 2010 with discharge data available on a population basis to elicit the cause or etiology, be it hepatitis B, hepatitis C, alcohol, fatty liver disease, for every single case of hepatocellular carcinoma in Florida. Overall, we were able to link nearly 20,000 cases of hepatocellular carcinoma, of which 3,700 were Hispanic. I repeat, this was nearly 20,000 cases of hepatocellular carcinoma. No cohort study will ever achieve this kind of numbers that we are able to link, match, and work with at the level of cancer registries. The overall missing values for variables of interest were all below 15%, so we imputed the remainder to get complete rates for each racial ethnic group. These are preliminary data for males only, and what we can see is that there are huge disparities in occurrence of hepatocellular carcinoma according to specific Hispanic group. We can see that between Cuban males and Puerto Rican males, which are the two majority groups in Florida, there is a threefold difference. So what we are seeing in the preliminary data is that differences by racial ethnic group according to causes of HCC are quite marked. For instance, for hepatitis C, which is the first cause of liver cancer in the United States, the rates are particularly high among Puerto Rican males, followed by US-born Mexicans. For ANFLD liver cancer, what we can see is that nearly all Hispanic groups have got higher rates than the other groups from the other racial ethnic groups, with the exception of Cubans and Dominicans. For alcohol, rates seem to be particularly high among the Mexican subgroups, whereas HBV is not really an important cause of hepatocellular carcinoma in Hispanic males. Finally, in my last slide, I would like to say that we are paying particular attention as to how to proceed to translate our findings from this project into a benefit to the community. In particular, we are thinking in forms of meaningful engagement with local clinicians in Central Florida, where Puerto Rican populations and potentially asymptomatic HCV positive communities are concentrated. Thank you very much.
So I want to thank Paulo for that wonderful talk, and to streamline, we're going to now move into our discussion panel section. So I'm going to welcome and invite, never mind, they've already done it all. There are three speakers to open their videos up, and we're going to begin with our discussion panel. There's already been a number of questions that have been sent out, and I again want to remind folks that if you have any questions, to please put them in the chat and or raise your virtual hand. And just to start things off, this question is to Kathy. This is with regards to cancer registries, and one of the questions I was asked was, how can we use cancer registries to fill the gaps in the data identified?
I think that there's a lot of opportunity, and some of the studies that were presented in just this session, I think, highlight it. It's sometimes difficult to collect information on every cancer that's diagnosed in the country, and the registries have a great potential, I think, to be used as a sampling frame or as the basis for different kinds of studies that can be done that maybe link or survey patients or find data from other ways to answer specific questions that you're not going to get very easily by trying to collect the information on every person. Mm-hmm. And I will use this opportunity to say that we do have a notice of special interest out to encourage people to apply for grants that use the registries as a basis and then supplement it with additional information so they can answer specific questions related to health disparities. We would like to collect all this information in the registries for every case, but that might not always be practical. And I think that, excuse me, special studies or research proposals are a good way to really utilize the information in the registries to get down into more detailed information that you need for studies.
All right. Just one quick question, then again to Kathy, then we'll move on to some other questions to the others. For SEER, how was nativity defined and determined or ascertained? You brought that up.
In SEER, I believe, I'm trying to remember because it's recoded, but I believe they really are looking mainly at whether you're born in the United States or outside. And there might be some information in there about where you're born, but I think that would probably be limited.
Okay.
So really, it's just whether you're born in the U.S. or outside. Okay,
just wanted to know. This question is for Maggie, I believe, and it came from Umberto. He says, there's a question was, do New York Puerto Ricans who are born in Puerto Rico, do they consider themselves to be foreign-born, given that they are U.S. citizens?
Yeah, that's a great question. So I believe for SEER that individuals who are born in Puerto Rico would be classified as foreign-born, but it's not a perfect measure. But again, it would be used to compare individuals born in the 50 United States to individuals born in Puerto Rico who later migrate to one of the 50 states.
Okay. And there was a comment on that. I think Scarlett mentioned that in SEER data, nativity is determined based on birthplace, a 3-digit code indicating country of birth. So thank you, Scarlett, for that. Okay, well, people are now coming out of the woodwork for the questions. I'm going to pose this one to, let's see. There's a question by Juan. The question was, could speakers comment on how accurate the last name-based algorithms were or are? particularly among US-born Hispanic individuals who may not have a Hispanic last name due to interracial or ethnic marriage?
I really don't know that I can answer that question about how accurate it is. I don't know. I'll ask if anybody else can contribute.
I think, this is my opinion, but actually the problem is more on the foreign-born side in terms of linkages because of the structure of the Hispanic names that the foreign-born Hispanics have. In terms of the US-born Latinos, it's difficult because it depends if you're a female and you take up the Hispanic name of the husband when you get married, or if you're a male. But the NAHIA algorithm has got some criteria to contemplate that.
Yeah, I think it's a great question. I don't know if maiden name is used at all in determining Hispanic surname, but definitely there's going to be some misclassification based on Hispanic surname, and it'll capture some individuals correctly, but others will be misclassified as Hispanic.
And I imagine as time goes on, this will just be a much more complicated issue with the continuing of the mixes of different people marrying across different groups. I know I'm going to open up to, I'm going to apologize if I mispronounced names. Is it Celine or Celine? I think you're raising your hand. And so Jennifer, you can unmute him and then he can pose his question to the panel.
Yes, excellent presentations, everybody. My question is to Dr. Pinero. I'm very interested in the study you did in Florida, but my question is, Florida is not a SEER registry, and we know the SEER registries have to do very extensive follow-up, including many different linkages to try and overcome the issues of correctly ascertaining death, perhaps in the absence of a social security number, which is the most powerful identifier for linkages. So I wonder, what would you expect to find in the states, and I'm of course very interested in California, where we would have very strong linkage portfolio to try and overcome the issue of lack of social security number and perhaps ascertaining the mortality better?
Yes, that's a great question. And I think it's one of the major sources of biases that we have in terms of whenever we're computing Hispanic survival. I think SEER does a great job, especially compared to other registries that only have passive follow-up. Having said that, there would be improvements. I had a slide on that, in which there could be more consideration towards the death linkages with Latinos because of the structure of the names, and maybe create different probabilistic linkages for people who do not have a workable social security number. That's one thing. The other thing I would like to point out is that the SEER rule for 95% of last contact date is not really fair in terms of comparing unbiasedly the different race ethnicities, because it's 95%, but what's happening is that what we're getting from the registries is that most of that follow-up is 95% because we're getting it based on whites and blacks. When we look at the loss to follow-up in Hispanics and Latinos, the rate of follow-up increases substantially. So if this rule was changed to be race ethnicity specific, it would help somehow balance the bias in terms of our survival estimates for each of these groups.
So in relation to that, since it was brought up that regarding SEER, and someone else brought this question probably for Kathy, since SEER doesn't cover all of the US, and this person had asked about Texas, but I imagined it could relate to other states with their growing Hispanic populations. So the question was, given that SEER does not cover Texas, which currently is based on the 2020 census and has a majority Hispanic population, could you provide some thoughts on whether SEER will expand to include states like Texas?
Well, SEER actually recently did expand, and they added a few more states, and Texas is one of the states that will be included. So Texas will be submitting data to be part of the SEER data set as well, as will New Jersey, which was added, and Illinois. So hopefully that'll help better represent Hispanic population.
Philip also confirmed that too. Thank you very much, Philip. Let's see. Probably there's a number of others in the chat. Someone had asked about how was the etiology of HCC determined? Oh, that's for you.
Okay, so this is quite complex and I didn't have much time in the slides and I think the sound of the recording wasn't great. I apologize for that. So what we do is we collected all the data from FCTS, which is the Florida Cancer Data Registry for 2005 to 2018, and then we matched it with three different data sets. One is not ready yet, so this is somehow preliminary data. The one that was largest and more encompassing was discharge data for all ages. So this is not restricted to Medicare, this is for all ages. And this is important because many cases of HPV and HCV related liver cancer occur before age 65. So our work was more encompassing in that sense. So what we do get is there is a list of codes for causes of hepatocellular carcinoma that have been used in previous NCI studies. There are others that defend, some specific codes for NFLD in specific, which is an important cause of liver cancer. So that was the major one. The second one was after some sensitivity analysis in which we saw that the discharge data would not differ much if we considered it prior to diagnosis or actually after diagnosis. We also used that certificate data whenever they had HPV or HCV causes for liver cancer or alcohol dependencies. And then the third one that we're waiting for that we haven't finished yet is a linkage with the Department of Viral Hepatitis from the state of Florida, in which we're going to link all these data to them to see which ones were we missing. I think the important point that I would like to highlight in that study is that we were able to actually match about 80-something% of 19,000 cases of hepatocellular carcinoma. This is huge, and there is no cohort study that is actually going to get to these numbers anywhere near that. So in that sense, it is a robust population-based study.
And following up about that, Sangeeta commented about, mentioned that, since you're working with clinicians on HCC data, this person is a surgical oncologist and at the University of New Mexico and is one of the original SEER sites. And because he's worked closely with NMTR, he wanted to request a comment on making a collaboration more productive. I don't know if you have any quick comments about that in terms of that.
Well, we did all this. I'm an epidemiologist, okay? So we did all this and we found these rates. So then the question that comes is, okay, you've got all these numbers, what are you going to do? Now, I don't know if you are able to see in the slides, we have a problem specifically on HCV related hepatocellular carcinoma among a Puerto Rican population, okay? And this is the same actually for New York, the numbers point towards the same thing. And there are explanations for this from their past in the country, be it iatrogenic or drug use in the past. And these results are mostly for males. So now that we have those rates, we're thinking about the best way to do some meaningful engagement with local clinicians in areas where Puerto Ricans are concentrated in the state of Florida. And in that sense, this is important because if you think about HCV, these are asymptomatic patients now that are HCV positive without knowing, and not all of them get screened for HCV. Now, we know that there is a recommendation from the CDC for everybody to get screened, but that is not in high proportion that every patient is getting screened for HCV. So if you can detect some of those, and if you can increase awareness among local clinicians in areas of the state where these cases are concentrated, I think this could potentially translate into a gain for the populations.
Okay. Thank you, Paulo. This question is probably for any of the speakers. The question is, do any of these speakers have experience with the virtual pooled cancer registry, VPR-CLS? And how accurate is the Hispanic origin information there?
So I do not. I don't know if someone else on the line might have experience.
I am familiar with the VPR. I believe the data comes right from the cancer registry, so it would be the same Hispanic origin and subgroup data that the registry has. Okay. So there would be some issues with the data, but it would be the best data that we have at a population level.
Okay. Okay. And Maggie, this question's for you, since you mentioned about issues about data. You know, when you were discussing about the for New York State, you know, you brought up a lot about issues about, you know, related to missing birthplace or missing follow-up information and non-random censoring by racial ethnic groups. And so I guess the question is then, how could we best use that registry data to examine cancer survival in Hispanic populations, given some of those limitations and probably others that you brought up?
Yeah, so I think there are a few things, and Paulo mentioned some of these in his talk. One would be to try to collect more accurate information through national efforts to try and improve the data that are collected or the linkage with Social Security. I think another would potentially be to use more advanced methods to do some of the analyses, possibly imputing some of the information, but again, it might not avoid all of the issues. It would probably help address some, but potentially not all. And then I think what Paulo mentioned, looking at more highly fatal cancers and using the data in that way to examine differences in survival would also be one way, since we know for those cancers, differences in survival, we can look at the time of death and potentially use the data more effectively to look at more highly fatal cancers. And I'll let Paulo follow up.
Yes, I mean, I had in one of the slides, you have to see my position. I'm just an associate professor. I'm not currently linked to any particular cancer registry, but I think if there is a national interest in terms of getting better data in terms of these Hispanic subpopulations, I think the big step would be for NCI to start encouraging that, at least in the cancer designated centers, because if it starts there, then it's reported to the central cancer registries, and then we could have much better data on this. This is one of the things that I talk personally, because I've been having, together with Dr. Erin Kobitz here, we've been working tirelessly to get this kind of information in our institutions, which are some of the most diverse in the entire nation. We're getting there, but you know, if there was a guideline from NCI, you need better information on these cancer patients. This would be a great plus for all of us, I think.
Paulo, you know, you brought up issues about indigenous populations, and so someone's asking for a comment about comparisons to American Indian or Native American, meaning that US-born Latinos could also check indigenous on forms and surveys that might help to start cross-population genetic links and discover similar biomarkers that help inform both detection, testing, and treatment. So could you comment a little bit about that, those comparisons?
Oh, wow. Oh, wow. I think there's a lot there, okay? What I highlighted is that we have this thought that Latinos come here, and then some of the prevalence of risk factors gets worse, especially among the US-born. That over time, the Latinos are actually going to get closer to whites in terms of their rates. And my comment was that when we study specifically this group, what we're finding is that that is not really happening, at least in this short period of time that I've been analyzing the rates. I haven't seen any approach to the white rates. What I have seen is that they persistently have a group of cancers, okay, that are increased in relation to non-Hispanic whites or in certain different proportions. And that overlaps very similarly to what we know about rates among American Indians. Of course, there is overlap in terms of genetics of these two populations. Having said that, I think that it would be worthwhile to study the socio-environmental context in which these two populations that have got different histories in the past, to what extent these factors are actually impacting their cancer rates in a way that seems to be somewhat similar between the two groups. So in terms of, you know, I'm by no means a specialist in the cancer epidemiology of Native Americans. It's a relatively small population, very difficult to study. There are specialists in the US in that particular aspect, but I think putting these two together would help us better understand what really is happening to our populations, especially the US-born Latinos.
And following up a little bit about that, so Celine is asking that he's curious about the potential overlap in this classification of Latinos and Native Americans in border states like California, Arizona, Texas, and New Mexico. So don't know whether
I'm sure there are issues there. I'm not the best person to speak about that. I'm based in Florida. Having said that, yes, there are. I mean, we've been seeing that some cancers, for instance, ALLs and kidneys, they go very, very close between the two groups. So maybe somebody from the state of California would be more of an expert in this, could comment on that.
Okay.
In terms of the, in terms of the misclassification between the two groups.
Okay. Earlier I saw, was it Greg? I saw you turn on your video, so I didn't know if you just wanted to say hi in public or did you have a question? And so I'm going to see if you wanted to ask, if it's possible.
No.
Okay. Let's see. Something, I forget who it was who brought it up yesterday, but there were a few things, Paulo, you brought up, I believe, Maggie, you brought up too, about salmon bias. And I guess I wanted to get a sense of how has it been assessed in a sense, or like in terms of how is that assessed, or how is that affecting estimates, or is there any studies that you've seen or you've done in terms of seeing, has that made an effect on the estimates and some of the incidents or survival outcomes that you've been looking at?
Maggie, do you want to?
Sure. Yeah, I know Frank Bosco, who used to be at the New York State Cancer Registry and now has his own consulting business. He's done some work on this to look at unlikely survivors who are individuals born in other countries who were diagnosed in the US with a highly fatal cancer and were still alive much beyond where you would expect them to be alive. So I think those are some data that indicate that some of those individuals were lost and likely went back to their country of origin after their diagnosis, and their follow-up information was never captured. I don't know if there's, and Paulo, you might want to speak to this, if there's a more extensive analysis that has looked at that. What Frank did, I think, focused on New York and didn't look at all of SEER.
I think in terms of cancer surveillance, there hasn't been anything specifically done on that. In other diseases, there has been. Now, the problem in cancer surveillance is that it's going to be very difficult to isolate that bias, because that adds on to the effect of other biases, as I mentioned in the presentation. So there is the name bias, there is the social security number bias, and then there is specifically the salmon bias, which is people that just go back to die. Now, I am not, this day and age, to be honest, I am not so, of the three biases, that's not my major concern, because with the Social Security Administration linkage that most of the SEER registries do, in principle, we should get a live date for people who go back, as long as they are still receiving Social Security money periodically. Now, that is not to say that, who knows how complete and how thorough that process is, especially from the data sources which are abroad. But I think it's a very complex situation, because there are multiple biases acting with the same result.
Okay. I'm checking here to see any more questions posed.
There was a question that I saw in the text about the populations, about NCI trying to estimate populations for between 2010 and 2020 for the subpopulations. And of course, if we're able to do that, it would be publicly available and available to registries. And I think there was a comment about the American Community Survey also collecting some information. And yes, we know about that. I think we're hoping to get age-specific populations for each year. And so that's why we would have to move to modeling to get that. I don't think that there would be enough information from the census to get that kind of detail.
I've been getting that from the ACS, we can actually get all the age-specific by sex, etc. Now, the problem, as I was mentioning, is that, there's going to be imprecision. If you take like 1 year alone, there's going to be a lot of imprecision. But in my studies, for instance, what I do is I put together 2006, 12 to 2018, and then that problem, obviously, because it's many years compiled together, then that problem is going to be greatly reduced. But it's something that I would encourage folks to explore because it's relatively intuitive, and it could give you good data on denominators for each of these populations.
Sure. Yeah, we're hoping to get something that we could look at trends as well. Trends are different, hopefully by year, but we will see.
Paulo, I think this one, another one for you. This is question is, to the extent that genetic ancestry is not and won't be available on a population basis, how important is accurate surveillance data on Hispanic specific groups? And should better data on these demographics be a priority in surveillance systems?
That was my question yesterday for the panel then, and then I got no answer. So I would have to answer that myself. If I have to answer that myself, I think that on a population basis, I don't think we're very far from reality for the Hispanics as a whole. For these populations, as my presentation showed, we are way far and there's a lot to go.
Mm-hmm. Okay. Oh, there's another question by Amanda. I'm gonna read this out. Beyond bias due to missing data, there's a socio-cultural hypothesis that part of the mortality advantage stems from socio-cultural components of Latino culture. Example, feminism. Could the speakers share their thoughts on how much of an influence these factors might have on the mortality advantage finding?
I think there are several issues here to consider. I would agree that more on the survival side of the equation, that indeed familism and familial structure might have particularly protective effect and improving survival numbers for Hispanics. What I think about the mortality advantage in the metric of mortality rates, I mean, we know that Latinos smoke less, and smoking is the #1 risk factor for cancer. So all the mortality rate studies that we are considering, we'll have to factor in that before we speak about the mortality advantage straightforward to Latinos. Well, that is true, but that is because, because of the diets, of course, but also because they smoke less. So there hasn't been any study that would factor in that part of the smoking into the mortality rates for Latinos and their mortality advantage in relation to non-Hispanic whites. So yes, familism is a factor. I don't think it's going to be the #1 factor, and their impact is going to be more on the survival metrics, more so than on the mortality or on the incidence side of things.
And certainly what we know about the misclassification on the death certificates isn't enough to explain the differences that we see. So there are definitely other factors. And I agree, it's incidence and survival that are feeding into mortality, as well as,
Correct.
factors, treatment, all of that.
And if I can highlight another thing that I see, we are all peer reviewers and we serve on panel sections and so on. One of the things that I've been noticing is that there is a lot of confusion between survival and mortality rates, and how the two concepts get mixed up in papers is disappointing, to say the least. So I think there is a need for to foment more people that are experts in this area, specifically of Hispanic ethnicity, that could somehow, improve the level in terms of the research that is being produced and the kind of feedback and scientific criticism that we could contribute with, so that we could elevate this kind of research to a better level. I mean, if I can just say one thing, I've been participating in panel sections in the past, about 5 or 6 times. I saw very few people with knowledge on epidemiology based on registries, and I saw a lot of grants based on registry data. So that's another thing that maybe NCI could possibly think about to include more and to incentivize more the knowledge of the specific aspects of epidemiology related to cancer registry data.
Okay. Another something that someone brought up is that yesterday someone mentioned about 2/3 or 65% of the U.S. Hispanics were born in the U.S. But we often assume majority are foreign born, but we're definitely seeing that changing. And how do you think that changes in how we just discuss this point in research and how we're approaching evaluating Hispanic populations? These questions for all.
I think there's a huge difference between the two groups, okay? And that has got to do with a lot of exposures that you accumulate just by the fact that you are born in this country, so you grow up in this country, etc. So racism, etc., etc. One of the things that I would like to say is that the two groups are not very comparable because the US-born Latinos are going to be very young in relative age compared to the foreign-born Latinos. When it comes to the cancers, and we know that cancers come from a later age, we're actually going to get more cancers from foreign-born Latinos than US-born Latinos. So when we look at the numbers and we say, oh, US-born Latinos are huge, yes, they are huge, but it's because mostly of the children that are coming. So I think US-born Latinos are going to be a very interesting group in the future because they're going to become huge, especially in children, because as you know, some cancers are affecting Latino children at higher rates. Having said that, it would be important to see if there's going to be variation among US-born Latinos, for instance, between Mexican US-born or Cuban or Puerto Rican, and we're not yet there because the numbers don't help for these other groups. Having said that, I think, and I'm convinced, and I've been publishing on this topic for a while, I think there are huge differences, and not considering birthplace, not because of the birthplace itself, but because of what it represents, it is a big minus in the terms of research that we are producing in terms of Hispanics.
Okay. Well, I think we're close to the end, and so unless there's any last lingering questions, I'm going to wait a little bit to see if any happened before. Okay. Well, I'm going to say one thing. Thank you so much to Paulo, Maggie, and Kathy. Thank you so much for your time, for those presentations, and for taking these questions. I know that this is a continuing and ever-evolving issue, and hopefully we'll definitely see more. And obviously, we're hearing a lot from Paulo saying, pushing cancer centers and many other places to get more information. So Paulo, just letting you know, we're hearing you, if anything. And anyway, we're going to start our next session, and I'm going to, and I believe that next session will be regarding knowledge and resource sharing, and I'm going to hand it over to Samdat, Dr. Samdat Mahabir,